Now, after a long gap of about 3 months, due to some unavoidable circumstances and the tragic thing, now we are again beginning our master class for the postgraduate students and also our physicians who are in the periphery. Now, today we have a very erudite speaker and the doyen of acid base and fluid balance, Dr. Sanjay Pandya from Rajkot, and he will be introduced by our, and the proceedings will be further taken by Dr. Shekhar Chakraborty from Siliguri, governing body member of API Central. Now I hand over my mic to our secretary, Professor Partho Kormokar. Please, Partho, start the procedure. Thank you.
Thank you, Professor Sarkar. Today we all know that Dr. Sanjay Pandya has given his kind consent to take a class, because once before, just the turmoil that started in West Bengal, just the week before, he had a class in master class, but that had to be postponed. Now we have he has again given his kind consent to start his class, and we are beginning after that turmoil with class of one of the most popular doyens in the field of fluid and electrolyte balance, that is none other than Dr. Professor Sanjay Pandya. So we are also very happy to know that he is just back from US just 2 days back, and whenever there is academy, he never says no. So within 2 days, he has given his kind consent to give masterclass in West Bengal chapter API. So today we are very happy. I am very happy to inform you all, the faculty members as well as our attendants, that today he is going to open his website through this class. So we are really feeling proud of that. And for that reason, for opening, before starting the class, he will open his website. And for that thing, we do invite our president-elect and immediate past-in, Dr. Professor Jyotirmoy Paul, as well as the chairperson of our scientific session, today's topic, that is Dr. Shekhar Chakraborty. I invite both of them to initiate the opening of his website, that is Dr. Sanjay Pandey's website, and please invite him and open his website before we proceeding for the class. Over to Dr. Jyotirmoy Paul and Dr. Shekhar Chakraborty.
Thank you. Good morning and welcome everybody in the ICP webinar. It is really my great pleasure to release the third edition of the Blue Con Fluid Therapy and its website. Fluid therapy electrolyte imbalance basically was a chapter, and mostly it is considered in the section of critical care medicine and nephrology traditionally. But Sanjay Pandey has made it a subject like nephrology, hematology, critical care medicine, cardiology. And Dr. Sanjay Panda's name has been synonymous with the subject of fluid therapy and electrolyte balance in universe. Fluid therapy is basically bread and butter for all doctors practicing medicine, gynecology, surgery, and whatever may be. But this part is often ignored, not given due importance, like antimicrobial therapy or anti-diabetic therapy or anti-hypertensive therapy, whatever may be. But Dr. Sanjay Pandey, this fluid therapy book, he has given enormous effect to highlight the issues of fluid therapy that can change the outcome of a patient who is admitted. I am very sure that his effort and his book and his website, student will be extremely fortunate and will be extremely benefited. And that will help in their clinical and day-to-day practice. I wish all success of his third edition book and website. Thank you. Thank you, Dr. Pandya, again. Over to Dr. Shekhar Chakraborty.
Good morning to all of you. I am Dr. Shekhar Chakraborty, will chair the session. It's my great pleasure to introduce Dr. Pandya and his book, because you all know that Dr. Pandya doesn't need any introduction to our gathering. He is a master of fluid and electrolyte balance its theory as well as the practical aspect. And he has made the whole thing, the subject, in a very simplified manner. That is the very important thing, that the simplified manner, so that the each and every postgraduate student can acquire the skill how to diagnose the different abnormalities of the fluid and electrolyte disorder. And he has written this book. The unique part of this book is that the 1/3 of this copy of the book is released in the website, and it is also amenable to download. I think you can, if it's possible, you can download that part also. It will provide an insight how the book is written and the important aspects of the fluid electrolyte balance, which is important for the clinicians. And it is free of cost. This amount of knowledge which is being provided in the website is the free of cost. And once you are acquainted with that, you can jolly well purchase the book, and you can enjoy the flavor of the whole book. So this is basically the idea of Dr. Pandya, to stimulate all the students to study the fluid and electrolyte balance, which is the very, he is one of the great teacher of this. Those who has already attended his program, they know how he teaches the complicated thing in a very simplified manner. So it is now I would request Dr. Professor Jyotirmoy Pal, our president-elect and past president, to inaugurate the website and the book of Dr. Pandya. Dr. Pandya, please.
Yeah, thank you very much, Jyotirmoy Pal sir, Chakraborty sir, and all API and ICP leaders. And I'm truly so happy that this such a good platform, which is spreading information across many pages. I got opportunity to deliver talk, and I got opportunity to launch this website. When Dr. Karmakar sir said that we would like to have it, I readily agreed. And then Sarkar sir, Nandini madam, everybody are here, and in their presence, first Jyotirmoy Pal sir has released the website. I will play a launch video, and subsequently we will go ahead with our academic educational part. So let me first play the video by which we will launch our website, and then subsequently we will go ahead. 1 minute, please.
Welcome to the fluidtherapy.org, your one-stop resource for practical and evidence-based information on fluid therapy. Fluid therapy is one of the most frequent and essential interventions in clinical practice. The 2024 third edition of Practical Guidelines on Fluid Therapy is the latest evidence-based update of this popular book, with over 100,000 copies sold since its first publication. The book supports clinicians in designing effective fluid management strategies for everyday clinical practice. To extend the benefits of this invaluable book, we have developed this fluid therapy website, offering free access to key chapters of the latest edition. Among these, the chapter on resuscitation fluids is available for free, providing crucial insights into fluid selection and its benefits during emergencies across various clinical scenarios. Fluid therapy in obstetrics is another vital yet often under-discussed topic. The website offers free access to all chapters covering fluid management during pregnancy, cesarean delivery, and preeclampsia. In addition, the website offers free access to chapters on essential topics like hemodynamic monitoring, total parenteral nutrition, and many more interesting subjects. Visit the fluidtherapy.org website today to explore these important resources. Share the website with colleagues and help spread knowledge about the latest advancements and best practices in fluid therapy.
Thank you very much, Jyotirmoy Pal sir.
Thank you. Thank you. I wish all success of your website and hope many new editions will come and will be released in future also. And I congratulate you for your all effort. Thank you, sir.
And now that we are very thankful to Dr. Pandya that he has agreed to take a class and master class on acid-base disorder. So this acid-base disorder is a very common problem, not only to the intensivist, but also to all the clinicians, being a physician, surgeon, pediatrician, gynecologist, orthopedic surgeons. And the basic knowledge of the acid-base disorders is very important, because one important issue is very important, that in our body, the nature has made the pH, which is very tightly controlled between 7.34 to 7.44. This blood pH is so tightly controlled in our body that a little deviation from this pH actually changes all the metabolic and respiratory problems in our body. So how we all know that how the physiology of these acid-base maintenance is so important for each and every activity, like cardiac function, neurological function, all metabolic activities, transmembrane action potential, and everything. So therefore, we would like to hear from Dr. Pandya today that how from this tight control of pH we are being deviated, and how we can identify the deviation from this normalcy in either in acidic side or in the alkaline side, and how we can approach to any patient who are suffered from a simple acid-base disorder to a complicated acid-base disorder. I wish that all of the attendees who are attending the program will be benefited immensely from the lecture of Dr. Pandya and his stepwise approach how to arrive at a diagnosis and manage an acid-base disorder. Over to Dr. Pandya.
Thank you very much for your kind words, Shekhar Chakravarti sir. In presence of such an august audience, to deliver a lecture on this subject is truly a pleasure and a privilege. Now, when we talk about fluid management, my slides are visible, sir?
Yes.
Okay, it's absolutely visible. Okay. Please continue.
Yeah. So, in all critical patient, we would like to go for evaluation of ABG and evaluate the patient. Now, for PG student who are new to this interpretation, they find it difficult, and therefore today I'm not going to teach you something serious. The title I have prepared is Fun to Learn Acid-Base Disorder. If you feel that it's difficult to interpret ABG, simple disorder, mixed disorder, triple disorder, I want to make the thing so simple. See, the subject I understand is difficult, confusing, creates headache. But today we are going to have fun to learn acid-base disorder, where I'm going to open the treasure, which will have fun, and nothing but fun. So if you are in serious mood to learn, no, just be relaxed. We are going to have a great enjoyment in interpreting the practical aspect of acid-base disorder. See, we order ABG because in some of the patient, we want to diagnose that what is the underlying problem. Accordingly, we plan the therapy if patient is on ventilator, and then we need to have it. So don't get panic. Physiological approach is simple, it's fun, and it's life-saving. So step by step, we will go ahead. And the last part is take-home photos. Take-home photos means whatever I'm going to discuss today, the important part will be in form of the photos in the last part, and therefore you can recollect and you can use it in day-to-day practice. So when we want to learn ABG, it's simple. Remember 4. Why? Because pH is 7.4, so there is 4. Bicarbonate is 24, so there is 4. PCO2 normal value is 40, so there is 4. So remember 4 and things are simple. When pH is less than 7.35, it is acidosis. When it is greater than 7.45, it is alkalosis. So the question arises that what determines pH? Answer is that there are only two things, bicarbonate and PCO2. Why I say that it is simple? Because there is no third parameter. Look at the bicarbonate, look at the pH, and then we go ahead. Whenever you see bicarbonate, it's metabolic. So in metabolic, when we say that there is a metabolic disorder, think of bicarbonate. There are only two disorders, metabolic acidosis and alkalosis. Likewise, when you see respiratory, think of PCO2. Again, only two disorders, respiratory acidosis and respiratory alkalosis. So this is what is the balance. That when we look at the bicarbonate, PCO2, when bicarbonate is normal 24, PCO2 is normal 40, then pH will be normal, that is 7.4. When pH decreases less than 7.4, it will lead to acidosis. When it increases, then it will lead more than 7.45, it will be alkalosis. So first, we will understand the primary disorder. Again, remember 4, because there are only 4 disorders. The primary change in bicarbonate, there are 2 disorders, that is metabolic acidosis and alkalosis. And if the primary change occurs in PCO2, again 2 disorders, that is respiratory acidosis and alkalosis. So there is no 5th disorder, and therefore I feel that learning this thing will be very simple. Now, when we talk about metabolic acidosis, the primary change occurs in bicarbonate. If the bicarbonate reduces, then reduction of bicarbonate will low bicarbonate and low pH will be characterized, will lead to metabolic acidosis. So metabolic acidosis is the condition where there is decreased bicarbonate, which can occur because of the increased bicarbonate loss, like diarrhea, or acid is added, like in diabetic ketoacidosis or lactic acidosis, or bicarbonate is not generated, like in patient with renal failure. Now, let us see other metabolic disorder, and that is metabolic alkalosis. Simple. Primary change occurs in bicarbonate. In metabolic alkalosis, bicarbonate increases, and that leads to increase in pH, and therefore metabolic alkalosis is characterized by high bicarbonate and high pH. The causes of metabolic alkalosis, if we look at, it's simple, that either it is excess loss of H-ion, like vomiting, or there is failure of bicarbonate excretion, which occurs from kidney because of hypovolemia, hypokalemia, or hypochloremia. Clinical conditions like vomiting, diuretics, and hyperaldosteronism can lead to the same. Now, when we talk about respiratory acidosis, the primary change occurs in PCO2. When PCO2 increases, that leads to reduction of pH, and therefore respiratory acidosis is characterized by high PCO2 and low pH. The causes can be many. All of you know well that there is increased accumulation of CO2, either because of hypoventilation or because of the reduced excretion of the CO2. And when CO2 increases, CO2 plus H2O will lead to carbonic acid. And when the acid increases, that leads to change in pH, and that is what is the respiratory acidosis. When we talk about the respiratory alkalosis, the last disorder, the primary change occurs in PCO2. When PCO2 decreases, that will lead to rise in pH, and that gives rise to respiratory alkalosis characterized by low PCO2 and high pH. So it's simple that whatever may be the cause of hyperventilation, that will wash out CO2, and when there is low CO2, that will lead to respiratory alkalosis. The causes are many. All of you know, I am not going to narrate the same. So to summarize, when the primary change occurs in bicarbonate, it can be metabolic acidosis characterized by low bicarbonate, metabolic alkalosis characterized by high bicarbonate. If the primary change occurs in PCO2, that will lead to respiratory disorder, respiratory acidosis characterized by high PCO2, and respiratory alkalosis characterized by low PCO2. After basic understanding, we will go ahead how to diagnose primary disorder. Now, we will go step-by-step analysis. And when for the first time we look at the ABG report, we feel confused that out of so many parameters, what to look at. But look at the pH, look at the bicarbonate, look at the PCO2. And that's how we are going to go ahead. And don't forget that to interpret ABG properly, we need to even perform serum electrolytes simultaneously. So the first step is that look at the ABG report. Is there any abnormality? So we look at the pH, bicarbonate, and PCO2. If they are abnormal, that means we are dealing with some acid-base disorder and we need to go for the next step. If all three values are totally normal, that means usually it's not, there is no underlying acid-base disorder. But in critical sick few patients, this can be exception. So we have looked at the ABG and we looked at the value, they are abnormal. So let us go ahead. So now in evaluation of ABG report, we will look at the pH first. And we would like to diagnose whether we are dealing with acidosis or alkalosis. So if pH normal value, all of us know, is 7.35 to 7.45. If pH is less than 7.35, it suggests acidosis. If pH is greater than 7.45, it is alkalosis. So start the practice. I'm not going to teach you. We are just going to discuss, and all of you are going to interpret the ABG like swimming. If we practice, then we can easily master interpretation of ABG, and therefore, like swimming, we need to do the practice. And today, I'm going to ask several clinical cases, and whenever you see flower, it's going to be your time. You have to evaluate the report which I am showing you, and all of us will have a enjoyable journey to interpret ABG. And therefore, I request all of you to answer together. Unfortunately, I'm not able to listen to your replies, but then I'm still with you. And therefore, let us start with the first interpretation, that look at the pH and find out what is the problem. Now, pH is 7.4. So what is the underlying problem? Yes, it's acidosis. pH is 7.5. What is your diagnosis? Look at the value. Yes, it is more than 7.45, and therefore it is alkalosis. And when it is 7.4, obviously it is normal. So always we will diagnose the primary disorder first, whether we are dealing with acidosis or alkalosis. Then comes that if it is abnormality is there, what is the underlying problem? So first we will try to evaluate the acidosis. So if in our ABG report pH is low, less than 7.35, and there is acidosis, we will look at the bicarbonates first. And if the bicarbonate is low, underlying disease is metabolic acidosis. If it is not low, then there are only two causes. Either it is metabolic acidosis, or if it is not metabolic acidosis, then it will be respiratory acidosis. And in respiratory acidosis, the PCO2 will be high. So look at the bicarbonate. If it is low, it is respiratory acidosis. If the PCO2 is high, it is respiratory acidosis. So low bicarb, metabolic acidosis, high PCO2, respiratory acidosis. That is how we should go ahead. If in our ABG, the pH is high, greater than 7.45, then it is alkalosis. So why there is alkalosis? Again, look at the bicarbonate. High bicarbonate suggests that the underlying cause is metabolic alkalosis. And if there is alkalosis, and if it is not metabolic alkalosis, we have to consider that it is respiratory alkalosis, and look at the PCO2. If the PCO2 is low, that is going to confirm that it is respiratory alkalosis. There is no third option. If it is alkalosis, high bicarbonate, metabolic alkalosis, low PCO2, respiratory alkalosis. That is how we will go ahead. So to summarize, when there is low pH with low bicarbonate, it is metabolic acidosis. High PCO2 with low pH, it is respiratory acidosis. If it is high pH, that is alkalosis. Then look at the bicarbonate. If it is high, it is metabolic alkalosis. Look at the PCO2. If it is low, it is respiratory alkalosis. So diagnosing primary disorder is something which is very, very simple. We would like to have, again, practice. We would like to diagnose the primary disorder. Always look at the pH first, bicarbonate second, and PCO2 last. Remember, always diagnose the change in pH. So look at whether it is acidosis or alkalosis. And then mention the complete diagnosis. It is acidosis, it's metabolic acidosis. It is alkalosis, it is respiratory alkalosis. In this way, when you will go ahead, it will be simple, easy, and it will be fun. So now look at the value. A patient of congestive heart failure on diuretics. The pH is 7.48. So considering pH, which is high, our diagnosis is what? It is alkalosis. Now, whether alkalosis is metabolic or it is respiratory. When we look at the bicarbonate is high, and therefore our diagnosis is metabolic alkalosis. To make this thing simple, look at the balance. That bicarbonate has increased, that has led to increase in pH, and therefore our problem is alkalosis and metabolic alkalosis in this case. Now, second case, pH is 6.98. So what is the underlying problem? Answer is that low pH means we are dealing with acidosis. Now, bicarbonate is 30. Can it explain acidosis? No, it cannot explain. So we looked at the PCO2. PCO2 is high, and therefore we have acidosis with high PCO2, and therefore our diagnosis is respiratory acidosis. So look at this balance, that there is PCO2 which is high, and because of the increased PCO2, there is reduction in pH, and therefore our diagnosis is acidosis, respiratory acidosis. Going for the third case, pH is 7.45. So pH is more than 7.45, and therefore what is the diagnosis? Answer is that it is alkalosis. Now, why there is alkalosis? Can bicarbonate 20 explain? No, bicarbonate is low, so it cannot explain. Can PCO2 25 explain? Yes, PCO2 is low, and therefore our diagnosis is respiratory alkalosis. This balance will clarify your concept that PCO2 has reduced, and because of that, there is alkalosis. It's alkalosis, respiratory alkalosis. And the last one, 7.2 pH. So a patient of diarrhea. So considering low pH, what is our diagnosis? Acidosis. The bicarbonate is 10. So can it explain acidosis? Yes. Bicarbonate is low, and that is suggestive of metabolic acidosis. So this is how we go ahead, and how simple it is. Systematically, step by step, we go ahead, and then it becomes easy. So after diagnosing primary disorder, now we will go ahead. So what next? It is the diagnosis of mixed disorder. So when we start the mixed disorder, after diagnosing primary disorder, we have to understand the concept of compensation. So after basic understanding, we diagnose the primary disorder, and now we will understand and discuss the concept of compensation. So what is compensation? See, to make the concept of compensation clear, we have to answer that what is compensation, how it occurs, what is same direction rule, what is expected compensation, and why to calculate and check the compensation. So the first question, what is compensation? If we go to, say, Himalayas, it will be cold. We would like to cover ourselves with lot many woolen clothings, while in hot atmosphere, we would like to wear white thin shirt. So that is what is the compensation. So it is body's defense mechanism which tries to maintain pH towards normal in various insult on pH homeostasis. When patient has metabolic disorder, primary change occurs in bicarbonate, there will be respiratory compensation, that will be the change in PCO2. When the primary disorder is respiratory, the compensation is going to be metabolic. There will be change in bicarbonate, which will try to compensate. So in metabolic disorder, the pulmonary lung compensation is comparatively fast. But in respiratory disorder, kidney takes time. And therefore, compensation occurs slow. Why this is important? Because in acute respiratory disorder and chronic respiratory disorder, if we look at the change, say in acidosis, there is increase in PCO2. So whatever change occurs in bicarbonate will occur slow. And therefore, this is something which is important to remember. Now, how compensation occurs? The metabolic disorders will have respiratory compensation. Let us say metabolic acidosis. In metabolic acidosis, low bicarbonate and low pH will stimulate respiratory center, and this hyperventilation will lead to, also known as Kussmaul's breathing, will lead to increased respiratory rate, will lead to washout of CO2, reduction of CO2, and low CO2 will raise the pH. So what was the primary thing? Low pH. What is the end result? The pH will be raised, and therefore the pH which was low, this compensation will try to bring towards normal, and this is what is the compensation. The second question, what is same direction rule? Now, if you look at this case, that primary change was low bicarbonate, and as a compensation, because of the hyperventilation, there was a reduction of PCO2. And therefore, look at the primary change, low bicarbonate. Look at the compensation, low PCO2. And that is what is the compensation. That compensatory change in acid-base disorder occurs in the same direction as primary change. Decreased bicarbonate leads to decreased PCO2. Increased bicarbonate leads to increased PCO2. Up yields up, down yields down. This is known as same direction rule. Okay. Now look at all four disorders where primary change and compensatory change will be in the same direction. Metabolic acidosis, both will be low. In metabolic alkalosis, bicarbonate will increase, compensation will be increase in PCO2. In respiratory acidosis, there will be increase in PCO2, and that will be compensated by kidney, and there will be increase in bicarbonate as a compensatory change. In respiratory alkalosis, primary change is decreased by PCO2, and the compensation will be in form of decreased bicarbonate. So this is what is the same direction rule. Now, what is the expected compensation? Now, if patient has metabolic acidosis, presume that in patient with metabolic acidosis, bicarbonate from 24 has reduced to 16. So what will happen to PCO2? Even the PCO2 will reduce. But then how much? To know this, we need to know that what is expected compensation. So every disorder has a special formula. If we look at the metabolic acidosis, in metabolic acidosis, when bicarbonate decreases, the value of PCO2 can be calculated by a simple formula. That is, PCO2 is equal to 1.5 times bicarbonate plus 8. So in metabolic acidosis, calculate PCO2. It is 1.5 times bicarbonate plus 8. All of you speak loudly that PCO2 is equal to 1.5 times bicarbonate plus 8. You should speak PCO2 is equal to 1.5 times bicarbonate plus so loudly that even I can hear here in Rajkot. So this is something which is important. So how do we calculate? See, here are some examples. That suppose patient with metabolic acidosis has bicarbonate of 20. What will be the expected value of PCO2? 20 into 1.5, that will be 28. and plus 8 is equal to 30, is equal to 30. Okay. Now, if it is 16, what will be the expected PCO2? 16 into 1.5 is equal to 24. 24 plus 8 is equal to 32. So that's how we calculate. So in metabolic acidosis, remember that PCO2 is equal to 1.5 times bicarbonate plus 8. In last part, there will be take-home photos where all formulas will be mentioned, and you can take the photo of the same screenshot, and then you can go ahead. So coming to next disorder, that's metabolic alkalosis. In metabolic alkalosis, there is increase in PCO2. But then how much will be the rise in PCO2 in metabolic alkalosis? Answer is that PCO2 rise is equal to 0.6 into bicarbonate rise. Okay. So in metabolic alkalosis, when bicarbonate increases, so how much is the magnitude of the rise in bicarbonate? Multiplied by 0.6 will give us the expected value of PCO2. So if we look at the metabolic acidosis with bicarbonate of 30, what will be the expected value of PCO2? Answer is that instead of 24, the rise in bicarbonate is 6 here. And therefore 6 multiplied by 0.6 will be 3.6. And therefore 40 plus 3.6, that means 40.3 will be the expected value of PCO2 in case of metabolic alkalosis. Likewise, if metabolic alkalosis is having bicarbonate of 34 or 44, the value rise will be 6 milliequivalent or 12 milliequivalent, and the expected value of PCO2 will be 46 and 52. So this is how we calculate. So to summarize, in metabolic disorder, if we want to calculate that what will be the expected PCO2 in metabolic acidosis, remember that PCO2 is equal to 1.5 times bicarbonate plus 8. PCO2 is equal to 1.5 times bicarbonate plus 8. While in metabolic alkalosis, PCO2 rise is equal to 0.6 multiplied by bicarbonate rise. So in metabolic alkalosis, when we want to calculate PCO2 rise, it will be simple 0.6 into bicarbonate rise. Now, how do we calculate in respiratory disorder? In respiratory disorder, when we say the change is calculated in reference to either rise in 10 mm or fall in 10 mm of PCO2. And it's simple. Remember 1/4 and 2/4. In respiratory disorder, remember 1/4 and 2/4. So what is this 1/4 and 2/4? In respiratory acidosis, 1/4 should be remembered. So what is this 1/4? Answer is that, see, when patient has acute respiratory acidosis, when PCO2 increases, the change in bicarbonate for every 10 nm for Hg will be only 1 milliequivalent rise in the bicarbonate. This magnitude is small because kidney takes time to compensate. And therefore, in acute respiratory acidosis, if we try to calculate bicarbonate rise, then 0.1 into bicarbonate rise, that is the simple formula. So suppose patient has acute respiratory acidosis with PCO2 of say 60, then how much will be the rise? Answer is that 0.1 multiplied by 20, and therefore it will be 2. So bicarbonate normal value is 24 plus 2 is equal to 26. Likewise, when patient has respiratory acidosis with PCO2 of 80 and 100, the rise will be 40 and 70, and therefore expected increase in bicarbonate will be 4 and 7, and value of bicarbonate expected will be 28 and 31. This is how we calculate in acute respiratory acidosis. With prolonged time, kidney compensate perfectly, and therefore for every 10 mm of Hg rise in PCO2, the bicarbonate will increase by 4. For acute, it was only 1, while here it is 4. And therefore, in respiratory acidosis, remember 1-4 formula. 1 for acute respiratory acidosis and 4 for chronic respiratory acidosis. So I may not go in detail of the same, but here is the example that if there is chronic respiratory acidosis, in that case, if the value of PCO2 is like 50, 60 or 70, the expected value of bicarbonate will be 28, 32 and 36 as calculated here. So just look at it for a while and then we will go ahead. Yes. Now coming to respiratory alkalosis. For respiratory acidosis, we remember 1-4. While for respiratory alkalosis, we remember 2-4. So now you are clever to understand that 2 is meant for acute. So for acute respiratory alkalosis, the change of bicarbonate will be 2, while chronic respiratory alkalosis, the change in bicarbonate will be 4. So in acute, for every 10 mm of Hg fall in PCO2, the bicarbonate will reduce by 10. Here is the example. Just look at the same for 2-3 seconds, and then we will go ahead. Yes, and when it comes to chronic respiratory acidosis, compensation is very effective. For every 10 mm of Hg, reduction of PCO2 in respiratory alkalosis, the fall in bicarbonate will be 4. And therefore, if we calculate here, if the patient has respiratory alkalosis with chronic respiratory alkalosis with PCO2 of 30, then in that case, 0.4 multiplied by 10, that will be 4. So 24 minus 4, so expected value of the bicarbonate will be 20. So in respiratory alkalosis, when PCO2 decreases, even the bicarbonate decreases. The reduction of the bicarbonate can be calculated by simple formula, that is remembering 1-4. So to summarize, in respiratory disorder, in respiratory acidosis, remember 1-4. In respiratory alkalosis, remember 2-4. And therefore, the calculation formula simplified for metabolic disorder, if you look at in metabolic acidosis, PCO2 is equal to 1.5 times bicarbonate plus 8. In metabolic alkalosis, PCO2 rise is equal to 0.6 into bicarbonate rise. In respiratory acidosis, remember 1-4. In respiratory alkalosis, remember 2-4. And with this, we will go ahead. Now, the question arises that why to calculate and check compensation? Why I took so much pain to see that all of you master the calculation formulas? Answer is that it is to differentiate simple from mixed disorder. If actual value and expected or calculated value are same, then disorder is simple. But if there is disparity in both, either it is high or it is low, that means we are dealing with some disorder which is a mixed disorder. And the last thing, that same direction rule, that up yields up, down yields down, and therefore, if the reports are in opposite direction, think of mixed disorder. With this, all of you are now ready and your concepts are clear. So we will go towards the approach to diagnose mixed disorder. All of you find it difficult, complex like chess, but we will make it simple. So the question arises that what is mixed disorder? Answer is that it's like volcano on snow mountain. Whether it is cold because of snow or it is hot because of volcano. Answer is that when both are present, it is mixed. So what is mixed disorder? It is defined as independent coexistence of more than one primary disorder. Mixed disorder commonly occurs in very critical ill patient, and the commonest disorder which we see in day-to-day practice is metabolic acidosis with respiratory acidosis. So here is some example that when there is, in which clinical condition there will be metabolic acidosis with respiratory acidosis. Answer is that shock with respiratory failure, or second important cause, diabetic ketoacidosis in patient with severe respiratory problems like COPD. Likewise, I will not able to discuss all, but metabolic acidosis and respiratory alkalosis can occur, and these are the various combinations. But my question to all of you, my friends, my PG friends, student friends, that can patient have metabolic acidosis and alkalosis present in the same case? Indirectly, I am asking that can patient have decreased bicarbonate, that is metabolic acidosis, and increased bicarbonate, that is metabolic alkalosis in a given patient? The simple logic to me says no, it cannot coexist. But if we look at the actual thing, yes, it can coexist. Why? See, look at the diabetic ketoacidosis who is vomiting. The diabetic ketoacidosis will lead to metabolic acidosis, and vomiting will lead to metabolic alkalosis, and therefore such patient will have near normal pH and bicarbonate. Severe vomiting with shock. Vomiting will lead to metabolic alkalosis, and shock can lead to hypotension and lactic acidosis. So metabolic acidosis and alkalosis can coexist in some of the patient. But very important that respiratory acidosis and respiratory alkalosis can never coexist. With this understanding of compensation, now again we are going back to diagnosis of mixed disorder, and now I need your best attention because we are towards the latter part of the interpretation. And to start with, so we have, well, first we have suspected, then we have diagnosed the primary disorder, now coming to the mixed disorder. And the first thing is that I would like to tell you about some magic trick. Magic trick to diagnose mixed disorder. Is it possible to diagnose mixed disorder just in 3 to 5 seconds? You will feel that no, it cannot be possible. But here is the trick. It's a magic trick to diagnose mixed disorder quickly and easily in just 5 seconds. In some of the cases, it may not be possible in all, but in some of the cases, it's possible. And what is this magic trick? Check direction of changes. As we have discussed, the primary change and compensatory change occurs in the same direction. And therefore, if we look at the direction of changes, it is expected to be same in simple acid-base disorder. But if change in bicarbonate and PCO2 are in opposite direction, think of mixed disorder. We may not able to know that which kind of mixed disorder is this, but it will give us a clue, very important, simple clue that this is not a simple disorder, this is a primary disorder, and therefore we have a practice time, and this is the practice time of magic formula, that look at the bicarbonate and PCO2 value and find out whether it's a mix or it's a simple. 20, 30. So bicarbonate is less, PCO2 is high, and therefore it's a mixed disorder. Bicarbonate is 34 and PCO2 is 48. Both are increased. So it's the same direction. We don't know what is going on. Likewise, I may not narrate all, but look at the bicarbonate and PCO2 direction of changes, and that may provide a very simple, easy to diagnose clue for the mixed disorder. Next, it may not be possible in all. So how do we approach the patient? Answer is that we calculate compensation. That is to diagnose the mixed disorder. When we calculate, as we already discussed, if the calculated value and actual value are matching, disorder is simple. But if they are not matching, in that case, disorder is mixed. As I was narrating, that patient of metabolic acidosis with bicarbonate of 16, what is going to be the expected value of PCO2? Now, all of you know that in metabolic acidosis, the PCO2 will be 1.5 times bicarbonate plus 8. So if bicarbonate is 16, 16 multiplied by 1.5 is equal to 24 plus 8 is equal to 32. So in metabolic acidosis with bicarbonate of 16, if the PCO2 is 32, we will say that it is compensated. But instead of 32, if the value is just, say, much less, instead of 32, it is 28, 25, 20, lesser, then the respiratory disorder which reduces the PCO2 is coexisting, and it is none other than respiratory alkalosis. But instead of 32, it's 35, 40, 45. That means it's high. It suggests that there is a disorders, respiratory disorders, which is coexisting, which can increase the PCO2, and that can be none other than respiratory acidosis, because respiratory acidosis increases the PCO2. So this is how we go ahead. And therefore, you need to remember the formula. In metabolic acidosis, PCO2 is equal to 1.5 times bicarbonate plus 8. In metabolic alkalosis, PCO2 rise is equal to 0.6 into bicarbonate rise. In respiratory acidosis, remember 1/4. In respiratory alkalosis, remember 2/4. And now we will have a practice. Okay. Now, pH is 6.98. So primary problem is, yes, it is acidosis. 27 is the bicarbonate. Can it explain acidosis? No. Look at the PCO2, 110 instead of 40. That means there is increased PCO2, and therefore our diagnosis is respiratory acidosis. Now, next comes the direction of changes. That with increased PCO2, we expect bicarbonate to increase. So how much is the bicarbonate? 27. So direction of changes, yes, both has increased. Now comes the compensation, that this thing has happened acutely, and therefore we feel that, oh, patient is having acute respiratory acidosis. And in acute respiratory acidosis, which formula will you use? Yes, out of 1/4, we will use 1. And therefore, for every 10 mm of Hg increase in PCO2, bicarbonate will increase by 1. So here it is 70. So 70 multiplied by 0.1 will be 7. So with PCO2 of 110 in respiratory acidosis, the bicarbonate is going to increase by 7, and therefore expected value of bicarbonate is 31. Now look at the actual value. Actual value is 27, while expected value is 31. So instead of 31, actual value is lesser. It is 27. Instead of 31, it is lesser, 27. And in which condition bicarbonate increases? Answer is simple. You are right. It's coexisting metabolic acidosis. So with calculating and comparing value, we could diagnose that patient has respiratory acidosis with metabolic acidosis, even though bicarbonate was greater than 27, greater than 24, and it was 27. So this is something which is simple. Now coming to other interesting case, pH is 7, a case of diarrhea. So acidosis is there. Bicarbonate is 10. Can it explain acidosis? Yes. It is suggestive of metabolic acidosis. Now, if we look at the direction of changes, with decrease in bicarbonate, we expect PCO2 to reduce. It is reduced, so direction is same. Now, in this case, what is going to be the expected value of PCO2? Answer is simple. We know the formula, 1.5 formula, 1.5 times bicarbonate plus 8, and therefore 1.5 into bicarbonate plus 8 will be 23. So expected value of PCO2 is 23, but actual value is how much? It's 36. So instead of 23, it is higher, and that is 36. So there is accumulation of CO2. And which condition leads to accumulation of CO2? Yes, you are right. It's respiratory acidosis. And therefore, this patient will have metabolic acidosis and respiratory acidosis. A case of severe diarrhea his serum potassium was just 2 milliequivalent, and because of the weakness of the respiratory muscle, patient developed respiratory acidosis, and this is what is the case. Now, one more case, a case of acute breathlessness with low BP. Blood pressure is, pH is 7.5, and therefore it is alkalosis. Why alkalosis has occurred? Yes, there is acute breathlessness, CO2 is washed out, PCO2 is 20, and therefore we have respiratory alkalosis. It's an acute breathlessness. So look at the direction. Decrease PCO2 is associated with decrease in bicarbonate, so direction is same. And now in acute respiratory alkalosis, if we look at the formula, yes, it is 2, and therefore fall in bicarbonate will be 0.2 multiplied by 20, because 40, instead of 40, the PCO2 has reduced to 20, so 0.2 multiplied by 20 will be 4, and therefore expected bicarbonate will be 24 minus 4 is equal to 20. Actual, how much is the actual PCO2? It is also 20, and therefore say expected bicarbonate is 20 and actual bicarbonate is 16. So instead of 20, when bicarbonate is less, it is 16. It is suggestive of coexisting metabolic acidosis. So patient has alkalosis, which is a respiratory alkalosis, and with that there is metabolic acidosis because bicarbonate is lesser than expected. Now, after this calculation, what next? See, there are something which needs greater attention. What is this? When you look carefully, you may find it's elephant, you may find it monkey, and therefore comes the problem where needs a greater attention is a CID skill to diagnose acid-base disorder, and that is to check anion gap. So in each and every case of where you evaluate ABG, look at the anion gap. So what is anion gap? Anion gap is sodium minus total of chloride plus bicarbonate. So what is the normal value? Normal value is 12 plus or minus 2. Now, why should we check anion gap? Answer is that if anion gap is high, it is diagnostic of hidden high anion gap metabolic acidosis. In some of the patient, when you look at the values and you look at the calculation, comparison of the calculated and expected value, all things seems to be normal. But when we calculate anion gap, if anion gap is high, it is suggestive of hidden high anion gap metabolic acidosis. So don't forget, anion gap is like footprint. You may not have evidence, but the footprint, with footprint, CID people find out the culprit. In the same way, you become CID skill and calculate anion gap and then measure it. It will suggest you of, if anion gap is high, it is suggestive of high anion gap metabolic acidosis. So anion gap is sodium minus total of chloride plus bicarbonate. The normal value is 12. So always calculate sodium minus total of chloride plus bicarbonate, measure anion gap, and if anion gap is high, it is suggestive of high anion gap metabolic acidosis. When the protein decreases, the anion gap will be affected. So we need to find out that how much is the fall in albumin, and then accordingly we have to add 4 milliequivalent for every fall in 1 gram of albumin, and that is how we have a corrected value of anion gap in interpreting ABG. Now, how anion gap helps us? Yes, it's not only diagnosis, but when anion gap is high, it tells us that yes, the patient is going to have some causes like ketoacidosis, lactic acidosis, renal failure, or some of the toxins. So if patient has acidosis and anion gap is high, the causes are different. And if patient has acidosis but anion gap is normal, then the causes is like diarrhea or renal tubular acidosis or urinary diversion or large volume of IV saline infusion. So this slide I had shown you before, that to interpret ABG perform serum electrolytes simultaneously, because anion gap is equal to sodium minus total of chloride plus bicarbonate. And therefore, you are supposed to have the value of sodium, you are supposed to have value of chloride, and therefore always perform serum electrolytes simultaneously so that you can go for the evaluation of anion gap and find out the hidden problem. So check anion gap. If anion gap is high, it is suggestive of high anion gap metabolic acidosis. Perform ABG and electrolyte simultaneously. They are made for each other. With this, we will go ahead. See, look at the ABG report. Vomiting in diabetics. pH is 7.4, bicarbonate is 24, PCO2 is 40. So all three reports are normal. That means there is no report. There is no abnormality. But look at the ketone. Ketone is present. That means it's abnormal. And therefore, although all three parameters are normal, we will go for CID skill. We will measure anion gap. So sodium minus total of chloride plus bicarbonate, anion gap, which should be around 12, is 30. Anion gap is high. And therefore, this patient is having high anion gap metabolic acidosis. Diabetic patient, ketone present, high anion. But then question arises that why pH, bicarbonate, everything is normal? Answer is that it's because of vomiting. See, vomiting will increase bicarbonate, ketoacidosis will decrease bicarbonate, and that will bring the pH closer to normal, value of bicarbonate closer to normal, and therefore this patient is having high anion gap metabolic acidosis with metabolic alkalosis, and this diagnosis we could clinch only with calculating anion gap by using CID skill. Now going to the last part, and that is diagnosing triple disorder. So now things are difficult, but all of you are skilled, ready to learn, and this is the last part of today's discussion. See, look at this. What is this? Looks like a can of cold drinks. But if you look at things carefully, it may be three dogs. So now comes the Mossad skill. See, Mossad skill is the final of the final. So to diagnose triple disorder, compare. See, it's only in high anion gap metabolic acidosis. So if anion gap is normal, we don't need to calculate this Mossad skill. Mossad will take care only through CID, and you and me cannot talk to Mossad people. So what is this last part? It's only in high anion gap metabolic acidosis. Compare rise in anion gap with fall in bicarbonate. So what is rise in anion gap? Rise in anion gap means anion gap, which we have calculated, minus 12. So just to make the thing simple, that if the value of anion gap is 26, then rise in anion gap will be 40. And for 30 and 32, the rise in anion gap will be 18 and 20. So rise in anion gap is equal to anion gap calculated minus 12. Now compare rise in anion gap with fall in bicarbonate. What is fall in bicarbonate? It is simple. 24 minus bicarb value which we have in ABG. So the value of bicarbonate is 20, fall will be 4. If it is 16 and 20, this will be the 8 and 12. So this is how we calculate, and therefore this is also known as delta gap or delta ratio. But to me, this comparing rise in anion gap with fall in bicarbonate seems logical, and therefore we will calculate and compare rise in anion gap with fall in bicarbonate. Now, why? Why we want to calculate this? How it helps in diagnosis? Answer is that when we compare anion gap rise with bicarbonate fall, we have three different possibilities. Number one, it can be same. So how we look at it? Answer is that when we compare rise in anion gap with fall in bicarbonate, And if both of them are equal, that means we are dealing with pure high anion gap metabolic acidosis. The second possibility is that as compared to rising anion gap, the fall in bicarbonate is less. See, instead of being equal, there is the fall in bicarbonate is less. And that means there is some coexisting disorder which can increase bicarbonate. Otherwise, see, if the rise in bicarbonate is 10, the fall in rise in anion gap is 10, the fall in bicarbonate should be 10. But instead of 10, if it is just 3, that means there is some disorder which can increase the bicarbonate. And which disorder increases the bicarbonate? Answer is that it is metabolic alkalosis. So when you compare as compared to rise in anion gap, if the fall in bicarbonate is lesser, smaller, that means patient is having metabolic alkalosis, suggestive of hidden metabolic alkalosis as a triple disorder. Likewise, the third possibility is what? That it may be the bicarbonate fall can be more than rise in anion gap. So as compared to rise in anion gaps, if the rise in anion gap is 10, but instead of that, fall in bicarbonate is 18, which is more, that means there is some disorder which can reduce bicarbonate. And which metabolic disorder can reduce bicarbonate? Answer is that it is normal anion gap metabolic acidosis. And therefore, it is suggestive of underlying hidden normal anion gap metabolic acidosis. This is how triple disorder can be diagnosed. So, this Mossad skill, compare rise in anion gap with falling bicarbonate, helps to detect hidden gain or hidden loss, and therefore helps to diagnose triple disorder. And when the difference is significant, it is useful. And now, before ending, I will summarize this Mossad skill and this only in high anion gap metabolic acidosis you can compare. So when you compare rising anion gap with falling bicarbonate, if both are equal, there is pure high anion gap metabolic acidosis. If as compared to rising anion gap, falling bicarbonate is less, means there is hidden bicarbonate gain. That means patient is having hidden metabolic alkalosis. And if the fall in bicarbonate is greater, say rise in anion gap is 10, but fall in bicarbonate is 18, that means fall in bicarbonate is more. It is suggestive of hidden bicarbonate loss, and that occurs in presence of coexisting normal anion gap metabolic acidosis. And this is what is the summary. So when we compare rise in anion gap with falling bicarbonate, we have 3 options. Equal means pure high anion gap metabolic acidosis. Falling bicarbonate lesser, smaller. That means there is disorder which can increase the bicarbonate, and that is metabolic alkalosis. If the falling bicarbonate is greater, means there is disorder which can lead to greater loss of the bicarbonate, and that can be normal anion gap metabolic acidosis. With this, we will have a Mossad skill calculation very rapidly, that if the rise in anion gap is 12, we have to compare with rise in anion gap, what is the fall in bicarbonate? Same, lesser, or greater. If it is instead of 20 lesser, that means hidden bicarbonate gain, that's metabolic alkalosis. If the fall in bicarbonate is greater, means there is additional disorder which can lead to bicarbonate loss, that's normal anion gap metabolic acidosis. If both are same, it's no additional disorder, it is pure high anion gap metabolic acidosis. And again, 2 disorders, that is where the bicarbonate loss is more, is normal anion gap metabolic acidosis. And the last, that rise in anion gap is 19, but the fall in bicarbonate is only 4. That means this is metabolic alkalosis. With this, I end interpreting. Again, I will summarize that suspect disorder, diagnose primary disorder, to diagnose mixed disorder, check direction of changes, calculate and compare check anion gap, that is CID skill, compare rise in anion gap with fall in bicarbonate, that is Mossad skill. With the last example, we will be ending this today's fun to learn acid-base disorder session, a case where following are the data, we will go step by step. pH is 7.46. So it is, yes, it's alkalosis. Primary disorder is what? Bicarbonate is 20. It cannot explain alkalosis. PCO2 is 29. And therefore, it's respiratory alkalosis. What is the direction of changes? Yes, PCO2 is less and even bicarbonate is less. So direction are same. Now, in respiratory alkalosis, what's the problem? See, with abdominal pain, there is alkalosis. It's a acute form, and therefore, if we look at the falling bicarbonate, it will be, see, out of 2,4, we will use 2 formula. So 0.2 into falling bicarbonate will be 2.2. So when there is falling bicarbonate by 2.2, expected value will be 21.8. And actual value of bicarbonate is what? 20, little lesser, but not very confident whether it's metabolic acidosis or not, so doubtfully. So now what next? What next? Answer is that CID skill, anion gap. So how much is the anion gap here? See, if we calculate the anion gap is 27. High or low? Obviously very high, and therefore suggestive of high anion gap metabolic acidosis. Now, when there is high anion gap metabolic acidosis, what next? Yes, Mossad skill. That is, compare rise in anion gap with fall in bicarbonate. So rise in anion gap is 15, but fall in bicarbonate is just 4. It should be equal. But instead of that, the fall in bicarbonate is less. That means there is hidden disorder which can increase the bicarbonate. It's none other than, loudly, I should be able to listen it. Yes, I could hear you are telling that it's metabolic alkalosis. And therefore, patient is having respiratory acidosis, high anion gap metabolic acidosis, and with Mossad skill, we could diagnose metabolic alkalosis. And therefore, what you have diagnosed is respiratory alkalosis, high anion gap metabolic acidosis with metabolic alkalosis is triple disorder. And therefore, from my side to all of you who have diagnosed triple disorder, congratulations and a lot of flowers for learning this ABG so interestingly and staying with me for such a interesting session on fun to learn acid-base disorder. With this, I will summarize that clinical correlation is important, etiological diagnosis is important. ABC should not be treated separately. It should be with patient. This is the beginning. And with this, I thought it was exhaustive, but I thought now you will find interpreting ABG interesting. So yes, I had promised that I will provide you take-home photos. But before photos, I take opportunity to thank ICP West Bengal branch, each and everyone who has given support to me. And this is the evidence-based book, Practical Guidelines on Fluid Therapy, with 12 parts and 750 chapters. It takes A to Z, everything regarding this. It's a popular book. In previous editions, some more than 1 lakh copies is sold. To extend the benefit of this book to all of you, today, I am thankful to our President-elect, Jyotirmoy Pal sir, for inaugurating this website, fluidtherapy.org. Simple name. Just go through it, and it will provide free access to key chapters. Don't forget to download resuscitation fluid because lot many changes are there. So go to fluidtherapy.org, click on it, download chapters which you love, which you like, and share with others because it's absolutely free. And now, as per my promise, take home photos. Yes, I will just wait for 5 seconds for every slide. Please take a photo of the screen because this will summarize everything. So diagnose primary disorder, look at the pH. If it is low, with low bicarbonate metabolic acidosis, with high PCO2 respiratory acidosis. If the pH is high, we have only two options with high bicarbonate metabolic alkalosis with low PCO2 respiratory alkalosis. Step by step, diagnose primary disorder, and then for mixed disorder, check direction of changes. That's magic formula. Calculate and compare, then check anion gap. That's a CID skill. And then last, compare rise in anion gap with fall in bicarbonate. That is Mossad skill. And with this is the final slide, which is important, useful. So calculate, remember the formula, and then this is the Mossad skill slide. Please take photo of the same. And with this again, I heartily, sincerely thank organizer for giving this opportunity to me to talk on this very interesting subject that's fun to learn acid-base disorder. With this, I will stop sharing my slides and back to all of you with my heartiest thanks to all dignitaries present in this webinar.
Thank you, Dr. Pandya. Now, now, Shekhar, please take a few questions from the chat box.
So thank you, Dr. Pandya, for your excellent and very lucid discussion on acid-base disorder. I think it is very, very helpful for all the students. So now I think I should say the
Chat box.
Chat box. Yes. There are the questions.
Sir, basically, this was an interpretation part. We have not touched to therapy or anything, and therefore, the question related to this may be invited, but sometime when it is convenient to ICP leaders, we will have something more where we can even discuss about
I think there is no question in the chat box.
Because this was an interpretation, and with
if the students has got any question, they can put directly to Dr. Pandya.
Yeah, we have already said that.
Actually, what happened, Dr. Pandya's elaboration was so lucid that it has he has forced all the details, all the interpretation, forced into the gray matter of juniors as well as seniors too. To be very honest, I have also learned many things from his lecture. I'm really, on behalf of API West Bengal, thankful to Dr. Pandya, and I will definitely request him to be in our master class in future too.